Hello, welcome to the Nestle Nutrition Institute's symposium on big care for the small and vulnerable babies. The fact remains that despite medical breakthroughs, premature birth is still a major health issue as it leads to death, long-term consequences, and difficulties that affect the child, the families, and society. And many of these can be prevented with medical intervention and education. We know that we healthcare professionals are part of the solution. Join us today as our experts talk about current updates on the care of these babies. We also have a special session that addresses the question of, should the small and sick babies be really separated from their parents during these challenging times? I would like to introduce the chair of the symposium, Professor Nadia Hayden. Nadia is Professor of Pediatrics and a researcher of the Neonatology and Pediatric Intensive Care Medicine of the Medical University of Vienna. She's also the head of the Neonatal Nutrition Research Team of the MUV. She's a member of the Spkang Nutrition Research Committee and the head of the Australian Pediatric Nutrition Committee of the Australian Pediatric Society, and an editorial board of Nutrients and Frontiers in Nutrition. Thank you, Nadia, and also to our speakers for helping shape this program. Together, let's save more babies and families. Thank you.
Dear ladies and gentlemen, I cordially welcome you to the World Prematurity Day that is observed on the 17th of November each year to raise awareness of preterm birth and the concerns of preterm babies and their families worldwide. The Prematurity Day was initiated 13 years ago by the European Foundation of Care for Newborn Infants and their chairlady Silke Mada, who is also one of our speakers today. The Prematurity Day is characterized by the color purple and by the socks line. Besides the color purple, which stands for sensitivity and exceptionality, the socks line has become a symbol for World Prematurity Day. The small pair of purple socks framed by 9 full-size baby socks symbolizes 1 in 10 babies is born preterm. Our symposium, founded by the company Nestle, today is Big Care for the Small and Vulnerable, and we have invited 2 brilliant speakers for you. Our first speaker is Professor Magnus Danilov from Sweden. Professor Danilov is professor at the Umeå University and a very well-known researcher in the field of nutrition of preterm infants, early interventions, and improvement of long-term health in children and iron metabolism. He was the chair of the Spkang Nutrition Committee. Spkang stands for European Society of Pediatric Gastroenterology, Hepatology and Nutrition, and his recent appointments were associate editor of GNPGN, which is the Journal of Pediatric Gastroenterology of Nutrition, the membership of the Royal Swedish Academy of Sciences, and he also developed a computer software for prescribing parental nutrition for preterm infants. Today, he will give us a lecture on the new Spkang guidelines for enteral nutrition of preterm infants. It will be published soon, hopefully. So please, ladies and gentlemen, welcome together with me, Professor Magnus Danilov.
Thank you for that nice introduction, Nadia, and I would like to thank the organizers to invite me to have this talk. And I'm going to talk about the updated Spkang guidelines for enteral nutrition of preterm infants, and I will try to focus on practical aspects. And here's my disclosure slide. I have received speaker fees from a number of companies and small research funding from Baxter and Prolacta. As you know, being born very preterm or with a very low birth weight is a nutritional emergency. We know that these babies face numerous nutritional challenges, starting with an almost complete lack of nutrient stores at birth, so they need nutritional support already from the first day of life. And they have extremely high nutrient requirements, which is easily understood because these babies would normally at least double their weight, and in many cases increase their weight by 3 or 4-fold during the stay in NICU, or neonatal intensive care unit. Furthermore, the prematurity in itself, including morbidities associated with prematurity, complicates parenteral and enteral nutrition, making it more difficult to nourish these babies. And the result of these factors, as well as a lack of proper guidelines and education, results in general malnutrition and postnatal growth failure, still be quite commonly occurring in NICUs in Europe and throughout the world. And why are we worried about that? Well, it's because it's not just growth that it's a problem. Growth is just a marker. We are more worried about the health outcomes. So we know that inadequate nutrition is associated with a number of health outcomes, such as severe metabolic disturbances, including, as you know, hypo and hyperglycemia, severe electrolyte disturbances, sepsis, necrotizing enterocolitis, osteopenia, bronchopulmonary dysplasia, retinopathy and prematurity, and poor neurodevelopment. So it's really important that we get the nutrition right. And we do have some quite nice and recent European guidelines for pediatric parenteral nutrition, which were published in Clinical Nutrition in 2018, and which were led by the Spkang, ESPEN, ESPR, and CSPAN. And these are for all children of all ages, but they have a very nice inclusion also of preterms. So they're quite useful. However, the enteral guidelines for preterms from Spkang are quite old. They are from 2010. They have been very useful, but it's certainly time for an update. So this is what I'm going to talk about, the updated Spkang guidelines on enteral nutrition. And these include a review, and a very extensive review, of all the evidence for enteral nutrition for preterm infants. And the focus is babies with a birth weight less than 1,800 grams. And we are not including the post-discharge period, but just the stay in the NICU. And the Spkang is, as you might know, the Spkang Society, the European Society for Pediatric Gastroenterology, Hepatology and Nutrition. And many of those involved in the Spkang Committee on Nutrition are neonatologists. So there has been quite a lot of focus on neonatal nutrition. And Spkang has appointed a writing group consisting of 18 invited experts and in total 25 authors, including committee members. And I must acknowledge Nick Embleton, professor from Newcastle, who has been the project leader. He has done a lot of work in this. And the whole work has been divided into chapters or parts, and each part has one lead author and 2 to 3 co-authors. And as you see here from this overview, of course, these guidelines are covering the nutrient requirements, which I will come back to. And the old guidelines mostly covered only the nutrient requirements, but these new ones include also sections on feeding practice, clinical management, and diet, which is we think is quite useful, and which will be the main topic of this talk. As you see here, the authors are very well spread from different countries in Europe, so good representation. And we had an initial small meeting in Oslo in March 2019, and then there was a lot of work going on during the following year. And in February 2020, we had a 2-day face-to-face meeting in Amsterdam when all these parts were already, or drafts for all the parts were presented. And here you can see us on the 4th of February 2020, and we look quite happy, and we think this is going very well. And what could possibly go wrong? Well, as you know, the COVID-19 pandemic happened, priorities had to change, clinicians were redeployed, we were not able to meet face-to-face, and the whole process was delayed. But now, September 2021, we can say we are almost finished. We aim to have this published later this year or early next year. And I must warn you that this is not finalized, so you should not use the numbers or quote any of the recommendations that I present here. because it's not completely finalized yet. But this is just quickly the recommendations for fluid and macronutrients. And as you can see, compared to the old guidelines, it's quite similar. It's almost exactly the same for fluid. It's a little bit higher for energy, and it's the higher upper limit has been increased for fat and carbohydrates to accommodate the variation seen also in breast milk. So no great changes here. For the essential fatty acids, there was quite only a recommendation for DHA in the old guidelines, and now there are recommendations for several essential fatty acids, and also the recommended intakes are a bit higher based on the recent research. For the minerals, some of them are exactly the same. Potassium, calcium, and phosphorus are higher than the previous guidelines. And the micronutrients, I just mentioned some of them. Most of them are quite similar to the previous guidelines. Zinc and copper intake recommendations is a bit higher, and vitamin D is now expressed per kilogram instead of just per day. So those are some news from the nutrient requirement side. But now I will go into the practical aspects, and I will not be able to present all the huge amount of data and research papers that these recommendations are based on. I will just take one example here, the very nice SIFT study presented or published in New England Journal of Medicine in 2019. It was a randomized multi-center trial performed in the UK, where 2,800 infants less than 32 weeks were randomized to increase their milk or food intakes by 30 milliliters per kilo or 18 milliliters per kilo, starting when the clinician assessed that they were stable after a couple of days. And the primary outcome was survival without moderate or severe neurodevelopmental disability at 24 months. And as you can see, there was no significant difference in the primary outcome. And importantly, also no significant difference in the risk of sepsis or necrotizing enterocolitis. So this is just one of the great studies that is the basis for these recommendations. So talking about then advancement of feeds, or starting with the initiation, there is no clear beneficial effect of enteral fasting or minimal enteral feeding of any duration compared to advancing feeds immediately after birth. So the recommendation is to start with small volume enteral feeds as soon as possible after birth and advance feeds as clinically tolerated. And then after day 4, faster advancement, meaning 30 to 40 milliliters per kilo per day, does not significantly increase the risk of NEC or mortality compared to slower. And faster advancement reduces the time to full enteral feeding, length of hospital stay, and possibly the risk of sepsis. So the recommendation in stable preterm infants, where the clinician considers that the feed volume can be increased, we recommend daily increment of 18 to 30 milliliters per kilogram per day, especially in breast milk fed infants. Now to gastric residuals. This has been a bit of a controversy because it has, in many units it has been done routinely and it has guided the increase of enteral feeds. But it has been shown in studies that gastric residuals alone are not a sensitive or specific indicator for bowel injury of the premature gut, and routine monitoring of gastric residuals actually increases the time taken to reach full enteral feeds and to regain birth weight, and increases the number of parenteral nutrition days, but does not have an impact on the NEC incidence. So the recommendation is to not routinely monitor gastric residuals in the clinically stable infant. So we have stopped doing that in our unit a couple of years ago, and I think many units have stopped doing that. However, assessment of gastric residuals should be performed when other clinical sites are associated with feeding intolerance or NEC, such as extreme abdominal distension, tenderness, emesis, bloody stools, etc. So now to the next bit. I should also give credit to Nadia Hayden, our chair here, who has been writing this part of the recommendations. This concludes that early progressive parenteral and enteral nutritional strategies may reduce cumulative energy and protein deficits. The transition phase between parenteral and exclusive enteral nutrition is a critical time period for cumulative nutrient deficits and for poor growth. This is quite an important observation. And the recommendation is that NICUs should develop standardized feeding guidelines and protocols for enteral nutrition. And now to the discussion about donor human milk and mother's own milk. We conclude that fresh mother's own milk contains higher amounts of macronutrients and bioactive factors compared to pasteurized donor milk. However, fortified pasteurized donor milk instead of preterm formula reduces NEC rates in preterm infants. So there's certainly, you can divide them and say that the mother's own milk is the best, and then comes the donor milk, and then comes the preterm formula. So mother's own milk should be the primary choice of feeding. And in case of insufficient mother's own milk, fortified donor human milk is conditionally recommended over preterm formula in preterms less than 30 weeks or less than 1,500 grams. This is a weak recommendation, but it's based on Cochrane review. There are a number of ongoing studies, so let's see if that will change in the future, but that's the current recommendation. When providing donor human milk, healthcare providers must continue to increase awareness of the benefit of mother's own milk and give lactation support, of course. Now to fortification, which has also been discussed a bit, especially in some countries. The recommendations from the expert group here is that it's reasonable to use a contemporary multi-nutrient human milk fortifier to enhance the nutrient content of breast milk given to very low birth weight infants, and to start already at enteral intakes of between 40 and 100 milliliter per kilo per day if clinical condition is appropriate. The use of concentrated high caloric special care products which are not intended for preterms instead of fortifier is not recommended. Individualized fortification strategies have the potential to improve growth, but the evidence is still limited. It's recommended to implement preferably as part of a clinical trial or a quality improvement initiative if you're not already doing it, of course. The exclusive human milk diet and the human milk-based fortifier is also something which is very much discussed and being studies are ongoing evaluating this diet. However, the recommendation from the group is that there is not enough evidence to recommend as a strategy to improve short or long-term outcomes, short-term outcomes such as necrotizing enterocolitis, sepsis, and death, for example, or long-term outcomes. Now to the mode of feeding. There is not enough evidence that either nasogastric or orogastric feeding tube placement is preferential. So unfortunately, we couldn't resolve that debate. Bolus feeding every second or third hour might be slightly more preferential than continuous feeding, but more studies are needed. The establishment of non-nutritive sucking prior to the introduction of oral feeding may reduce the time to reach full oral feeding and the length of hospital stay. So that seems to be useful. And the recommendation is to introduce oral feeding, or introducing oral feeding should be guided by the competence and stability of the preterm infant and may be started from 32 weeks postmenstrual age. Buccal colostrum has become quite popular to give unpasteurized colostrum in the mouth early on, and going through the literature, the conclusion is that while the administration of buccal colostrum to premature infants appears safe and theoretically attractive from both an emotional and immunological point of view, no clear clinical benefits for the infant have consistently been proven in high-resource settings. And the recommendation is that use of buccal colostrum may be considered in all preterm infants, given that the parents agree. And that relates to the next point here, pasteurization to avoid cytomegalo infection. And it's interesting to note that the CMV virus looks a bit like the coronavirus, but it's of course a totally different virus. And it's known that this can be transmitted to the preterm infant through the mother's own milk. So that's a conflict. Should you give the mother's own milk from CMV positive mothers, or should they be tested or pasteurized and so on? So the recommendation is, while we acknowledge the potential adverse consequences of postnatally acquired CMV, especially in the most immature infants, there is insufficient evidence to recommend routine pasteurization of mother's own milk from CMV positive women, as pasteurization reduces the activity of many bioactive factors in fresh mother's own milk. So now to osmolarity. There has been also some discussion about osmolarity, and maybe we should test all feeds for osmolarity. It seems that the effect of osmolarity is not as strong maybe as has been suggested in some from some people. But osmolarity of milk feed should preferentially be less than 400 milliosmoles per liter, and supplements or other feed additives should be added to the largest possible volume of milk feed. Multi-component fortifiers should be used in preference to multiple individual nutrient supplements to reduce osmolarity. And hydrolyzed protein formula may be used for early enteral feeding in very low birth weight infants because it accelerates gastrointestinal transit and enteral feeding advancement, but no data shows that routine use improves long-term outcomes. So probiotics is not a focus on these in this paper because it has been previously published by the Spkang first network meta-analysis showing that certain strains of probiotics reduce the risk of necrotizing enterocolitis, and then recently published Spkang recommendations from last year where it is shown that at least 2 of these promising strains can be recommended for preterms less than 32 weeks to prevent necrotizing enterocolitis. But it's important with good manufacturing practice to make sure that there is no contamination. So there's some caveats that you can read in this paper. So this is just briefly referred to. So what about other bioactive supplements that you can add to the food and give health benefits? Choline has been discussed because it has been associated with improved neurodevelopment in animal studies and so on. There is already in the previous guidelines stated that there is a nutritional requirement of between 18 and 55 milligrams per kilogram per day. Routine extra choline supplementation is not recommended in these new guidelines. However, milk formula designed for preterm infants should include choline in concentration to meet the recommended intakes. And then there are a lot of other bioactive supplements being evaluated, and some of them are listed here, and there is insufficient evidence to support the routine use of those listed here, and some of them is because they have been undergone large randomized controlled trials and they have not been shown to be effective to improve health outcomes, and that includes lactoferrin, bile salt stimulated lipase, and inositol. And then for some other components, they seem to be promising, but there's not yet enough evidence to support routine use of these supplements. And those include milk fat globule membranes, nucleotides, lutein, zeaxanthin, and human milk oligosaccharides, which will be the topic of the next talk. Very interesting. Now to growth. Growth was a big discussion point, and one problem is that we all use the fetal growth as some sort of gold standard, but actually the optimal growth velocity that optimizes outcomes in preterm infants remains unclear because there are no RCTs that we can base this on. But the recommendations in this part is that regular growth monitoring should be performed, weight daily typically, and length and head circumference typically once per week. Growth should be monitored using a growth chart based on a large, robust data set. Here it was a lot of discussion if we should recommend one specific growth chart, but there are preferences. Some people like one growth chart and some like the other one. And we think that as long as it's not research but clinical work, you should just base it on a large, robust data set. For example, the intergrowth 21 is not very good because it includes a very, very small sample size of extremely preterm infants. So it's not very useful in that group. But most other growth charts used for preterm infants are fine. The postnatal weight loss should be less than 10% with a nadir at day 3 to 4. Regain of birth weight should be accomplished by day 7 to 10, and then growth should be maintained along or slightly above the current percentile or standard deviation until hospital discharge. So here it doesn't include any recommendation of catch-up growth. However, in small for gestational infants and appropriately for gestational age infants with postnatal growth failure, some catch-up growth should be allowed, but rapid catch-up growth should be avoided. And here we are thinking about minimizing the risk of later on metabolic syndrome, cardiovascular disease, diabetes, etc. A gradual transition should occur to the corresponding percentile on the WHO postnatal growth chart before or at 44 weeks postmenstrual age. And NICUs should adopt a standardized approach to the management and investigation of growth faltering. Now, this is my last slide here, and I must remind you of the limitations of my presentation here. Many of these recommendations are based on low-grade evidence. Some of them are based on very nice randomized controlled trials and all, but many of these recommendations, unfortunately, still low-grade evidence. This is a consensus of 25 experts after going through a vast amount of literature, including the very most recent papers. This is labeled as a position paper. It's not a formal guideline or protocol, so you all have to do your own guidelines and protocols more locally, and you can, of course, go through the evidence for yourself. We encourage you to do that. I would not like you to use the presented data here as written because phrasings have been modified by me here for brevity, and also changes may occur before publication. So thank you very much for your attention, and I would like to acknowledge once again Professor Nick Embleton, who was the project leader. Thank you very much.
Our second speaker today is Jean-Michel Hasqueux, Director from the Division of Neonatology at the University Hospital of Nancy. He is also a very well-known researcher in the field of breastfeeding, neonatal nutrition, newborn hemodynamics, and neurodevelopmental outcome. He has co-authored more than 170 publications and is the co-founder of the French Board of Neonatology and member of the American Academy of Pediatrics. Professor Hasqueux will give us a lecture on the clinical relevance of human milk oligosaccharides in preterm nutrition and present new and relevant data from a recently conducted study. Please welcome together with me, Professor Hasqueux.
Dear colleague, I'm going to present data on HMO and the preterm infant clinical relevance. First, I'd like to disclose that this presentation was funded and an honorarium received from Nestlé. In term-born infants, the total number of bacteria is about the same as the total number of human cells. These bacteria may be divided into beneficial bacteria with a positive effects on functions in the body, neutral type bacteria, or harmful bacteria. The mostly represented beneficial bacteria in term-born infants is bifidobacteria. But what about premature infants? We don't really know what would be the most beneficial bacteria in these infants. We don't know either whether microbiota and morbidity may be related in premature infants. In the EpiPage 2 national cohort study in 2011, we evaluated 3,161 premature infants. Their gestational age ranged between 24 to 41 weeks. In this cohort, 106 infants presented with necrotizing enterocolitis over a stage 2 of Bell. The infants had a higher risk of NEC in case they had a slower rate of feeding or less breastfeeding. In a subset of 94 cases, we were able to evaluate microbiota. Indeed, we showed that microbiome was associated with NEC. As you can see on this graph, we have the NEC cases in black and the controls in gray. The infants most colonized with Clostridium were most likely to present with necrotizing enterocolitis in this study. Interestingly, the infants colonized mostly by Bifidobacterium did not present any NEC. In the EpiFlor study, 577 infants from the EpiPage 2 with stool analysis at 1 month of age were followed up to 2 years postnatal age. The gut microbiota was grouped into 6 clusters in the study, 1 cluster being not amplifiable because of too low bacterial load. Then we have 5 other clusters. The first one mostly represented with Enterobacter, the second one mostly represented by Clostridium, the third one by Escherichia coli Shigella, the fourth one by Citrobacter, and finally, the fifth one by Staphylococcus. In this study, we showed that gut microbiota was associated with NICU practices and 2 years clinical outcome. First thing, we demonstrated that cluster 4 and 5 were significantly from infants younger than cluster 3 that came from more mature infants, and that was taken as a reference for that reason. When we compared the different clusters, we observed that for late onset sepsis, skin to skin within the first week of life, or breastfeeding within the first week of life, the more mature cluster was significantly different from the Enterococcus, Staphylococcus, or no bacteria cluster for all of these parameters. When we looked at the 2-year outcome with a criteria of evaluation that was DEF or neurodevelopment assessment with age and stage questionnaire below 185, again, we observed a significant and important difference between the infants who had a more mature cluster at birth, rather at 1 month of age, rather than Enterococcus, Staphylococcus, or no bacteria. Then we would like to modulate microbiota. Besides maturation of the infant, microbiota may be influenced by prebiotics. Among them, HMO, such as 2-fucosyl-lactose, have been demonstrated to beneficially influence microbiota. Human milk oligosaccharides represent up to 25% of human milk carbohydrates. They are indigestible for the stomach and the intestinal tract. They are represented from 5 elementary units, such as glucose, galactose, N-acetylglucosamide, fucose, or sialic acid. They are made of a core of lacto and bios, where is branch unit of lactose, and either a unit of fucose or sialic acid. HMO are not only prebiotics. They have been shown to also have direct antimicrobial property. They may have anti-adhesive possibility. They may be epithelial cell modulators or even immune cell modulators. This slide shows the association between microbiota and HMO. In this study, Corpola et al. Compared the microbiota of infants born by vaginal delivery or by cesarean section. They also compare in these infants those who received HMO in their mother's milk, either when they were born vaginally or by cesarean section. The authors showed that there was no difference whether the infants received or not HMO in their mother's milk when they were born by vaginal delivery. On the contrary, there was a significant difference in favor of the infants who received HMO in their milk when they were born by cesarean section. Overall, the authors concluded that 2-fucosylactose HMO in mother's milk may alleviate the effects of cesarean birth on infant gut microbiota. That study was performed in term-born infants. HMO content in human milk may be very variable. This may be due because of maternal genetics. It has been shown that the mothers may have a secretor profile for specific HMO, such as 2-fucosylactose, or a non-secretor profile. Likewise, that has been shown that there is a significant difference when the mother delivered prolifery with less 2-fucosylactose in their milk than they were born at term, and that lasted for 3 weeks. In 63 different mothers, Gabrielli and colleagues confirmed that there was some secretor mother and some mothers with non-secretor profile. They showed that for specific HMO, there may be some non-detected HMO in the milk or high level, and they also demonstrated that again for specific HMO, there may be a significant difference between the rates of the HMO in the colostrum or in more mature milk. Of note, that was really seen for specific HMO, but not all of them. Moreau and colleagues showed that there may be an increased risk of necrotizing enterocolitis and late-onset sepsis in 410 neonates with a gestational age of 28 weeks, ranging from 23 to 32. And in this cohort, 1/3 of the infants had mother with a 2-fucosylactose low secretor phenotype. The authors observed 26 dead. 15% were from the low secretor group versus 2% in the high secretor group, and that was statistically significant. 22% of the infants presented with necrotizing enterocolitis versus 7% in the high secretor group. That was significant. And again, gram-negative late-onset sepsis was higher in the low secretor group rather versus the high secretor group. In this study, Maisy and colleagues showed that a low level of specific HMO may be associated with NEC. They performed an HMO profiling in mother's own milk in infants with NEC versus controls. They showed that the level of a single HMO, that was here DSLNT, was significantly lower in mother's own milk received by infants with NEC. They calculated a threshold level of 241 nanomole per milliliter, as you may see on this slide, with a sensitivity and specificity of 0.9 for NEC. When they performed a microbiome analysis, they showed that there was a lower bifidobacteria and higher Enterobacter cloacae relative abundance associated with DSLNT level. Finally, Moreau and colleagues again showed that HMO may be associated with a protection against diarrhea in breastfed infants. In this study of 93 breastfeeding mother-infant pairs, studied from birth up to 2 years postnatal age, they evaluated milk samples obtained from 1 to 5 weeks postpartum. They divided their population into low, intermediate, and high levels, defined by the first, second, or third tercile of the population. They showed that regarding the level of 2-fucosylactone in milk, there was a significant risk of Campylobacter diarrhea when this level was too low as compared when it was intermediate or high. When looking at the whole fucosyl oligosaccharides in milk, again, they observed a significant higher risk of severe diarrhea with low level as compared to intermediate or high level. Well, all these studies raise the question on may HMO supplementation have a benefit on microbiota and beyond in preemies. Clinical safety and efficacy data are required in order to address that question. This is why we performed an intervention study on the effect of a liquid supplement containing 2 HMO in preterm infants. The goal of this study was to demonstrate feeding tolerance among preterm infants measured by non-inferiority in days to reach full enteral feeding in the HMO versus the placebo group. Shorter time to reach full enteral feeding would be an indication of adequate gastrointestinal tolerance and helps to provide sufficient nutrition to assure growth and impact the outcome. Secondary outcome would be growth parameters, gastrointestinal symptoms, adverse events up to 12 months corrected age, fetal microbiota, gut maturation, and breastfeeding HMO composition. Here is the protocol of the study. The design was a prospective, randomized, double-blind controlled trial in 27 to 33 weeks gestation infants in French centers. Early administration after 24-hour feeding was advised, and in any case, before 7 days postnatal age. As you can see here, when the infants had 24 hours of trophic feeding, they started the product and was this period of pre-full enteral feeding. Then, when full enteral feeding was reached, an evaluation was done every week up to discharge. Both enteral feeding volume above 150 ml per kilo per day and parenteral nutrition discontinuation was needed to define full enteral feeding. The product is a colorless and odorless solution of 260 milliosmol per kilo concentration of 0.1 gram per milliliter. It is composed of a mixture of 2-fucosyl-lactose and LLNT ratio, LLNT on a ratio of 10/1, and a dosing of 0.125 given 3 times a day as it reflects breast milk composition. It is given before gavage or feeding when the infant is mature enough for sucking. The results. In black, the results of the HMO group, in blue, the placebo group. There was no difference in this study between the two groups for gestational age in weeks, the rate of very low birth weight infants or extremely low birth weight infants. There was no difference either for weight for HZ score, length for HZ score, head circumference for HZ score at birth. There was no difference for the rate of small for gestational age infants. The sex distribution was even. There was no difference for cesarean section, and the postnatal age of the first product administration was identical in the two groups. About the exposure to intervention and milk feeding, there was no difference with the two groups, again, the HMO group in black and the placebo group in blue. The treatment duration, the pre-full enteral feeding period was not different between the two groups. The duration of treatment during the full enteral feeding period was not different between the two groups either. There was no difference for donor human milk and mother's own milk between the two groups before or during the full enteral period. Prevalence of formula feeding increased through the full enteral period feeding in the same amount in the two groups. Primary tolerance outcome. The non-inferiority of time to reach full enteral feeding was achieved in this study. In addition, when we looked at the adjusted mean time to reach full enteral feeding, there was 2 days shorter in favor of the HMO group, but this was not significant as the study was not powered for that. Looking at growth and short-term outcome. When we look at the weight for age Z-score evolution, you have in red the HMO group, in blue the placebo group. As you can see here, there was no significant difference throughout the study for the weight for age Z-score. But when looking at the head circumference for age Z-score, which has exactly the same profile as the length for age Z-score, we observed that there was no difference throughout the study, but as discharge, with a moderate but significant benefit in favor of the HMO group for head circumference for HZ score and length for HG score. There was no difference between the two groups for morbidity. We observed low average gastric residuals, ranging from 0 to 3 mils per kilo per day. The mean stool frequency was around 3 to 4 stools per day. We observed 3 NEC in the HMO group versus 2 in the control group. No late onset sepsis in the HMO group and 2 in the control group, and that was not significant for either of these indicators. 1 abdominal distension versus 4 were observed with diarrhea in placebo, and 1 versus 2 adverse event caused product discontinuation. None of these parameters was significant between the two groups. So in summary, we may say that the primary endpoint of tolerance, non-inferiority in time to reach full enteral feeding, was achieved in that study. In addition, we had a trend toward a reduced time to achieve full enteral feeding of 2 days, but this was not significant. Weight gain was similar. Head circumference and length was slightly greater and discharge in the HMO group. So we may suggest that HMO supplement may support improved early postnatal growth. Finally, comparable outcome of gastrointestinal symptoms and gastrointestinal adverse events were not different between the two groups, allowing us to conclude that HMO supplementation is safe and well tolerated in that population. So in conclusion, in premature infants, gut microbiota may show different patterns correlated with Nicu practices and immaturity, and may be associated with morbidity and clinical outcome. Macrobiota appears to be associated with HMOs in preemies, and specific HMOs milk content may be associated with short-term clinical outcomes such as NEC, late onset sepsis, or even death, and long-term outcomes such as diarrhea or neurodevelopment. HMO supplementation, given as soon as possible after birth, is safe and well tolerated. It supports age-appropriate growth in weight and is consistent with length and head circumference improved early postnatal growth. I'd like to thank you for your attention and thank the co-investigators of the study I just presented to you. Thank you very much.
Our third speaker will be Silke Mader, who is the chairwoman of European Foundation of the Care for Newborn Infants, EFCNI. As a mother of an extremely preterm infant, she has been a passionate and influential advocate for maternal and newborn health for more than 20 years. She established EFCNI and the World Prematurity Day in 2008, and since then she has been the author and editor of many publications on topics related to maternal and newborn health, and she received several national and international awards and medals for her engagement. Today, she will give a lecture on better care, a call for zero separation of parents and preterm babies, which is related to the complicated situation of preterm babies and their parents in the COVID situation. So please welcome with me, Silke. The floor is yours. Thank you.
Hello, thank you very much for inviting me as one of the speakers for the World Prematurity Day webinar of Nestlé Nutrition Institute. It is a pleasure for me to talk today about the impact of COVID-19 on intensive care units for newborns and what's the parents' perspective. The reason why I'm doing this work, and maybe some of you know me already, I'm also myself a parent who had a preterm birth 24 years ago. It is a long time ago, but at the moment, I really think sometimes it is the same situation as we had 24 years ago when we had our preterm twins born in Munich in an intensive care unit. We had one chair, which we had to share with all the other parents. Our children were born with 515 gram and 290 gram in week 25. 25 after I had a severe preeclampsia, HELLP syndrome, and we had 3 hours visiting time at this time in the afternoon. And you see here one picture where I kangaroo Lucas. It was the first time 1 month after he was born, and our daughter Lena died after 1 week. And the last picture you see my husband Oliver. It is on Father's Day, and in Germany Father's Day is in May. After 3 months he was able to hold the first time his son. And at the moment in the pandemic we have a very similar situation, and I always thought after all the work I have done it's over, but it seems it's even worse at this time. I would like to give you some background information. I mean, all of you know very well that preterm birth and its complication is one of the leading causes of death under 5 years of age. And in all over the world, it is really a challenge. Some countries are much better than others, but we have all over the world the challenge of preterm birth. The pandemic last year arrived all over the world, and we still can remember on these terrible pictures we had from China, we had from Italy, and also from Spain. And in the meanwhile, we are used to have this virus in our world, but for babies and parents born preterm, it's really a challenge. What we have recognized after just a couple of days and weeks that all over the world neonatal units really struggled with the situation that parents had no access to their babies anymore. There was really a huge restriction in these units, and our parent organization addressed this to us when we were in the beginning of the pandemic. The separation, as we all know, can result in long-term health challenges for the babies, but also mental health problems for the parents when they have no access or very limited access to their babies. And again, parents are no visitors, parents are parents and should have always access to their baby. We know that the survival benefit of kangaroo mother care far outweighs the small risk of death due to the COVID-19 infections. And even when we all know this, the hospitals still have these restrictions also when we have access to vaccination, or we have access now to much higher hygiene measurements. The experiences our parent organization shared with us brought us to the decision that we want to look deeper in the situation of parents who have their baby in the neonatal units, or how the parents also experience during birth or even in the time of pregnancy. What we have done is we developed a study, a global multilingual online survey in 23 languages, thanks to our parent organization and healthcare professionals who helped us to translate it. We got a donation from Novartis, and we collaborated with a lot of parent organizations all over the world. So with the neonatal societies, with the parent organizations, we collaborated with NITCAP and also with the nurses. And in the meanwhile, the first publication is already out and the second one is under review. The global report itself will be published or is already published then on November 11. What we have asked about the situation during the pregnancy and at birth. We have asked about the parental presence and the skin-to-skin situation. We have asked about the infant nutrition and the breastfeeding, and also about the communication and the health information the parents have received, and the mental health and the support the parents have got. We have finally received 2,103 participations from 56 countries. We had inclusion and exclusion criteria, and we asked the parents in the time of the 1st December 19, inclusive the 30th of November in 2020. And the parents, of course, had to be in the intensive care unit with their child, and they had to be, of course, parents and not healthcare professionals. So therefore, some experts also tried, I guess, to go through this survey. Here you see the map, which parent organizations or parents which parents have answered the questionnaire. And you see here also a lot of gray areas. And the reason why we not reach these regions in the world is that we have no parent organizations and support from this country. So there is still a lot to do for us to get established parent organizations in the low and middle income countries. We asked in this questionnaire if mothers or fathers have answered the questionnaire. So you can see here in the first slide that the majority of participations were mothers. We also asked if the mothers or if the parents were positive tested or the child were positive tested. And you see here also that the majority of parents who participated and still experienced this enormous restriction were negative tested. Also the child were negative tested, and even being negative, the parents experienced such big restrictions. What we have asked in the time frame of pregnancy and the delivery time frame, we asked them if they were permitted to be accompanied by a second person during their pregnancy appointments. And you see here that many or most of them were not allowed to bring a partner or a company person with them. And also in the time of the delivery itself, so during birth, the majority of parents could not bring any partner with them. And we know from WHO that it is strongly recommended to be not alone in the delivery situation and also to have a partner with them at pregnancy appointments. What we have asked also about the parental presence and the skin-to-skin care is that mothers were allowed to be with their babies in 74 cases, and in 53 cases it were the fathers. Maybe you say now, well, that's not so bad, but it means that every fourth mother were not allowed to be present with their baby, and every second father were not allowed to be with their babies in this time frame. So that means that 1 in 4 had no access in the end to their baby, and that is quite severe, because when you just count the amount of babies that you are not allowed to be with your baby, that's quite severe. How often were you permitted to have skin-to-skin contact? And again, it's evidence proven how important is skin-to-skin care. And here you see that 28% were not able so far to kangaroo with their baby, to have skin-to-skin care, and 9% only less than once a week. How often were they even allowed to touch their baby? Maybe you say here also, well, 80% were allowed to touch the baby. That means that 1 out of 5 were not allowed to touch their baby. So just imagine you have a baby in the hospital and you are not allowed to touch it, or you're not be allowed to hold it, or even not to be allowed to see it. That's quite a big number. How often were you allowed to see your baby receiving a special intensive care? Here you see that 37% were all the time allowed to see their baby. And then you go in purple that only 15% have never seen the baby. Maybe you say, well, compared to how often parents can see their baby, is it a small number? But again, 3% had only less than once a week access to their baby, once a week 4%. And if you just imagine you have a child in the hospital and around 15 and another 7% have very strict limitation to even see the baby. We are not talking about touching or kangarooing, it's only seeing the baby was such a big restriction. What's about the nutrition and the breastfeeding? Here we see it's a little bit better that the parents or the mother was encouraged, highly encouraged to breastfeed. It's also to somehow we're encouraged to breastfeed. It's not so bad. But again, we want to have breastfeeding or fully breastfed babies. So parents should always be encouraged to provide mother's own milk. And when you see also who was exclusively able to breastfeed, it's around the half of the babies, and partly breastfed 40%. The challenges in the first time of the pandemic was, of course, that 70% were able to provide pumped milk, so expressed milk, and there were also, of course, restriction in not leaving the house, for example, in the very first time of lockdowns. So there was no opportunity to breastfeed or pump at home and provide the milk then in the end with bottles to and send them to the hospital, because of big restrictions even to leave the house. So how was the communication and the mental health in this time frame? Do you feel to receive adequate information about COVID-19 when discharged from hospital? Here we see that 1/4 had not at all information to get in the end information for discharge and follow-up at home, and also any kind of information what is important for knowing when you go home in the pandemic with such a baby. We also have to say that even the hospital staff had not all the information. So it was a challenge for both sides, the healthcare professionals, but also the families. And what kind of support was offered to you? And here you see also that around half of them have got no support. I also brought you some parent voices, how they have experienced it. It was terrible for my husband not being allowed to see his baby for nearly 6 weeks. He said he felt totally disconnected from her. I felt the wearing of mask in the unit was inhibiting bonding with my baby. I couldn't kiss her or hold her too close to me, and I didn't want her held up against a dirty face mask. Facilities for parents to make a cup of tea and use the toilet were all closed. Never felt comfortable in the unit because of this. Just imagine a woman who has freshly delivered and in the end has no access to toilets or any kind of facilities. She should drink a lot because she should provide breast milk, but it was not possible at this time. And even today, we have not all hospitals open again as it was before the pandemic. I could see my baby for the first time only 1 month after his birth. Terrible. A baby needs both parents to develop and get well. You should always be allowed to be with the child. It's crazy what is being done with the psychological health of a young family at the moment. We have received such kind of messages really from all over the world. There's not really an excuse of countries who have not experienced such situations. What are the conclusions? We have heard that prenatal care appointments and the birth mostly occurred without having a support person present, leaving childbearing women without emotional, informational, and practical support. The presence with the newborn and skin-to-skin care were heavily restricted and still is heavily restricted, especially for fathers. Breastfeeding support was mostly maintained, but we have heard also that providing pumped milk is or was still a challenge. Communication and mental health support were inadequate or lacking, putting additional stress on parents and in an already challenging situation. What we are calling for. We are calling for change and also the evidence-based cornerstone on infant family-centered developmental care. It needs to be in place again, and it should stop because we have the hygiene measurements in the meanwhile, we have the opportunity to test, and we have the access to vaccination. We call for a zero separation policy and an immediate, sensible, and compassionate lifting of existing restrictive visitation policy. Parents are no visitors, parents are parents. Infant family-centered care must be reinstalled where it was discontinued, it must be promoted where it was questioned, and it must be protected where it was restricted. And I would close my presentation with these 2 pictures. You see one picture where a mom only can hold a picture of her baby because she has no access to them. Just imagine how bonding should take place, how this mom feels all the time, and also when the baby comes home. Some of the parents have seen their baby not at all. That means after 4.5 months, they get their baby not knowing if it is theirs. Then you see the other picture where both father and mother can bath their baby, feeling they are the parents of this baby. There is a need of changing the minds. It has to be done now, and we have to act to change the situation for a more normal family baby bonding. And we hope we can start now and not have to wait until the pandemic is over, because it will still take some months or potentially even years. Thank you very much for your attention.
So welcome back from our talks to the Q&A session. I'd like to thank all the speakers for their brilliant talks, and I would like to encourage the audience to ask some questions in the chat. We have already received a few, and I'd like to start with the first question, which is from Magnus. There are a few questions on the new Spkang guidelines. One is on the protein reduction. So in the former guidelines in 2010, protein recommendations were higher than now. Can you comment on that? What is the reason behind that?
Yes, thank you very much for that question. Well, in the previous guidelines, there was a higher recommendation for the smallest preterms, less than 1,000 grams, where it was kind of assumed that these babies would have a poor nutrition, and this higher protein recommendation was to compensate for an initial period of poor nutrition. However, first of all, we see that now by a proactive management, we can prevent this early protein deficit. And also there are no studies really showing that a protein intake of more than 4 grams per kilogram per day really would benefit these babies, and rather there can be some concerns for even adverse effects. So we say that giving more than 4, up to 4.5 can be useful if the baby doesn't grow well, but the regular recommendation would be 3.5 to 4.
Okay, great. And there's a second question on the guidelines about growth. Does this mean that the Spkang does not recommend to use the intergrowth even for babies over 33 weeks? So we're talking about the different growth charts, and the question is if we should use the intergrowth growth charts now.
Yes, I mentioned the intergrowth that they had quite poor data below 28 weeks, but above 28 weeks, I think it's fine to use the intergrowth. Yes. Mm-hmm. Just check that your growth chart is based on a good population.
Yes. Okay. So we don't recommend specific ones, but the WHO, the Fenton growth charts are as well fine as the intergrowth, right?
Yeah.
Okay. Then a question for Jean-Michel on HMOs. In the 2010 guidelines, we did not recommend prebiotic or probiotic supplementation. And how do you evaluate this recommendation nowadays, especially with the upcoming number of clinical trials on HMOs? Should they be recommended now? Are we ready for that?
Well, thank you for the question. I think it's really a difficult question, but we're going from guidelines that were established in 2010, and now we are working with trials. And so we need to wait for the results of a trial to go further. But this trial has reached a new point, is about microbiota maturation. We were in 2010 on the concept that we would like to have especially for preterm infants, a microbiota as close as possible to the one we have with term infants. But now we know that, and it has been demonstrated, I recall that on one of the first slides I presented, that actually we have a maturation throughout the maturation of the infants. We also have a maturation of microbiota. So instead of trying to give probiotics, it seems appropriate, but this is pure speculation at this point. So we need to wait for the results of the trial again, but it seems appropriate to use HMO to enhance the maturation, to improve the maturation, rather than trying to replace the actual microbiota of the infants. That's why we're going now. So it's more to try to improve the maturation, accelerate the maturation, rather than replace the microbiota of the infants.
And is there already a therapeutic use in infants with necrotizing enterocolitis? Is there already a therapeutic option for HMOs?
Alors, at this point, as far as I know, HMO has been mainly used for prophylaxis to prevent and to set up an appropriate microbiota. We know that on specific points that it may also have a therapeutic effect, but we need for specific trial to be able to answer that question. There is no real way at this point to say that it could help during NEC, whether we may think that specific HMO would probably help preventing NEC, but that's a different option.
Right, okay, thank you. Then a question for Silke. I combined two questions. Has there been a significant progress in hospital arrangement guidelines with the campaign of zero separation? And how receptive are the doctors or neonatologists with the zero separation campaign?
Yeah, thank you for the question. We have started the campaign last year already, shortly after the coronavirus came in our regions of the world. And we started this because of the huge separation we saw in several hospitals, not in all of them. But what we can share is that, for example, a country like Norway, who really have an open, welcoming policy and had this a lot from many years on, they have closed their NICUs for fathers, not for all parents, but for fathers. And because of a huge campaign and also with an open letter to politicians and healthcare professionals, just in a few weeks, they changed their policy to welcome both parents, fathers and mothers, because fathers are not parents in a second line. And also a very nice example we have from Poland, where there were very strict regulation, and because of the campaign we realized already last year and World Prematurity Day, we used for speaking up for this, and they reduced in the end, of course not a welcoming policy of 24 hours, but they have opened their NICU, so they reduced this limitation or restrictions to a few hours per day. And also in UK and Ireland we had the situation, they had 5 minutes per day for the mother mainly, and there was a campaign of 5 minutes are not enough, and so therefore afterwards the NICUs opened more and more. But a welcoming policy like Magnus have in Sweden 24/7 and having welcoming policies for everyone, that's really rare all over the world.
Okay, and was there a change in this welcome policy at the doctors, with the doctors? Have you seen there anything change?
Well, it depends really on
the doctors.
Yeah, especially the doctors. Well, we had already before a limitation of a welcoming policy, so we really have to look into the countries per se. But we know, for example, from countries where you are coming from, Nadia, that there were in the first wave of the pandemic, there was a very strict restriction. Yes. And then afterwards, we realized how the virus spread. There was then a more open policy to, well, I would say minimum the mother who was able to join, but still today, and we have now the fourth wave, we close at the moment again the hospitals, and this is something what we have to take into account, what we are doing here, how we harm in the end, and the long-term consequences of the separation, of course, compare to the hygiene measurements we have to take, because we also don't want that doctors and nurses get sick and cannot work finally, and also the huge burden they have anyway already on their shoulders.
Right, thank you. Then again, a question from Magnus on the type of protein. There are a few questions on the hydrolyzed protein in formula and in fortifiers. I think this is not everywhere over the world the same. Shall we use hydrolyzed formulas in general when feeding preterm infants? And which type of protein should we add when we fortify? And should we fortify also pasteurized breast milk?
Yes, thank you for those questions. Well, there is some data that hydrolyzed protein formulas for preterms can improve gastric emptying. So that's what we state in the recommendations. When it can, and I think that at least in Sweden, most preterm formulas and also most human milk fortifiers, they already use hydrolyzed proteins. For the fortifiers, I'm not aware of any really good studies. So we don't really have a good conclusion on that. But and then the other question was about modular protein fortification, and certainly we would use we use in Sweden mostly targeted fortification. So we analyze the mother's breast milk for macronutrient content, and then we add a regular human milk fortifier, multi-component fortifier. And then if the breast milk is very low in protein, we might in some cases add also a modular protein fortifier on top of that. But it's, in my experience, it's actually quite rare that we do that, but we have that option.
Mm-hmm. And in terms of pasteurization, do you make a difference in fortifying pasteurized or native breast milk? This was also a question.
No, we don't, but we do use the targeted fortification. So we analyze, and of course, when you do analyze, you will see that your donor breast milk will normally be a little lower in protein than the mother's own milk. So if you don't analyze, I think it's a good practice maybe to give a little more, add a little more protein to the donor milk.
Because donor milk has low protein content. Yeah, right. Okay. Then another question for Jean-Michel. Is there a role for HMO as a therapeutic diet?
We mentioned it before, and I think at this point, as a therapeutic it may not be the good option because we don't know. So we would need to look at that again. We really think the more and the more data are coming out from the trials that we think that HMO may influence maybe a booster system or priming effect, and should be given as early as possible to set up an appropriate microbiota. We don't know yet really whether it could be useful as a therapeutic option, probably maybe to reinstall microbiota after antibiotics, for instance. But at this point, we still don't know, and we need to study that. We need more trial to be able to address that question. Okay,
thank you. And also a question on allergy for Silke. Any effects on foreseen increased allergy cases among infants due to too much hygiene practice in this pandemic area? But I think this is just a theoretical question. But have you observed worries in parents that
not about the hygiene? What we really have seen also in this research study is that the parents had challenges when they wear the mask, and they felt that the mask is dirty, that they kiss or touch the baby. That was something what we have heard, or that they were over careful about everything of their baby. But preemie parents are anyway always, when the baby is coming home or also in the hospital, very careful in having the hygiene measurements. Well, always, of course, not 100%, but the majority of parents really take care of this. And I guess important is that we not in the end ruin the whole natural relationship, the bonding and everything, because of all these hygiene measurements. And that is all, of course, we have to take care of it, is not what I mean, but we also have to see that there is a new human being coming, and that also needs bonding, kangaroo mother care, and breastfeeding, and you cannot 100% ensure everything. So it's also a new human being who is there and needs the skin-to-skin care, needs the voice and everything from the mother, from the father, and also from the doctors and nurses. They are treating them, so they can also not always 100% doing this perfectly.
Yes, right. Then another question on vitamin D for Magnus. There is a person attending who wants to know about the new Spkang recommendations for vitamin D that are lower than the previous ones. Can you comment on that?
Yes, thank you for that question. So actually the numbers are lower, but they are expressed per kilogram. So if you count on a 1.5 kilogram baby, they will be very similar to the previous guidelines. And actually most of the vitamin D supplementation studies that these recommendations are based on are done on babies in the vicinity of 1.5 kilo. But however, there's very, very tiny babies, maybe 500, 600, 700 grams babies, they have not been studied really to give those high doses. So they will receive a lower absolute dose per day, but we express it instead per kilogram. So it will be adjusted by weight.
Right. Then a question for Jean-Michel. Any evidence that HMOs in mother's milk delivering preterm babies associated with milk microbiota?
Sorry, ask it again. I'm sorry.
Is there any evidence that HMOs in mother's milk delivering preterm babies are associated with milk microbiota? So is the preterm, do we see changes in the HMOs of the mother of a preterm baby in contrast to a term baby?
Oh, okay. I was just a little bit upset or concerned about the milk microbiota idea.
Yes, I think this was the translation.
Was not close. Okay. Yes, there has some difference, and it has been studied, and we have the results, and especially to start with, and we think that's very important to make a supplementation as we present during my presentation during the first 2 to 3 weeks, because we know there is a significant difference between some specific HMO from the babies born from delivered prematurely rather than term infants. And we think it may be related to part of the difference we may see in the constitution of microbiota. And again, we are on a maturation process, and we probably may improve the maturation with appropriate HMO, specific HMO, of course, that may be lacking at the beginning of a baby from mothers who delivered prematurely. So the answer is yes, there is a difference, and we start to work on this difference to improve the situation for the premature infants. I hope I answer correctly the question.
Yeah, I think there's a lot of interest in HMOs as a therapeutic option for preterm infants, and I think these questions are related and eager to learn more about it. Then again, for Magnus, a question on growth restriction. We have 2 questions here from Indonesia. The first one is preterm infants are at higher risk for postnatal growth restriction in some countries and neurodevelopmental behavioral problems, and the risk increases with decreasing gestational age. So what is the proper way to stimulate it? And there is also another case related from a person that describes a 24-weeker, 10 weeks old, who has already reached an enteral intake, obviously a growth restricted infant, and an enteral intake of 100 ml per kilogram per day on human milk fortification, and that baby experiences constipation. So in basically 2 questions on growth restricted infants and how to make them grow. Can you comment on that? Are there specific recommendations for these group of patients?
Yes, thank you. Yes, as described in this coming guideline, actually we know very little about the optimal growth pattern, but what seems to be the consensus based on the most recent data is that the babies are allowed to lose some weight initially during the first 3 to 4 days of life, maybe 5 to 10% weight loss. And after that, they should probably stay on the same centile in the growth chart and should just grow along that centile. And so that's probably the optimal growth. But as one of the commenters mentioned, in some cases, we do observe still some postnatal growth restriction in the Nicu. This is especially common in the extremely preterm, the very, very tiny preterms, and those who have a lot of other complications. And of course, it's good that we are proactive and try to give as good parenteral and enteral nutrition as possible to those babies, but sometimes you really cannot prevent it. And then I think if you have got a severe postnatal growth restriction, you should be allowed to do some catch-up, but we don't think you should push that catch-up to be very rapid, because we don't really know the optimal speed of catch-up growth. But during a couple of months, that baby should probably normalize the percentile. So that was the growth thing. And then the other question was a baby who had probably some very immature gastrointestinal tract or some very severe problem, who was not on full enteral nutrition, even though the baby was 10 weeks postpartum. So in that we sometimes we do see this, and of course we should try to advance the enteral feeds as tolerated, and you should. Sometimes this baby, also it depends on what you mean, because it was mentioned that this baby has constipation. What is meant by constipation? This is also quite controversial. How often should this baby have feces, for example? Should it be several times per day, or should it be daily, or should it be every second day? Well, I think at least, you should be. Sometimes we see that the staff can be a little overly cautious with increasing the feeds. We have, for example, stopped testing the gastric residuals, and it's also mentioned in the guidelines that you should not do that routinely. So if the baby has no immediate gastrointestinal complication, I think you should try just to advance the feeds, and usually that can also help to mature the gut and to make the whole the defecation also easier, but over time. But still, we do see some very immature guts in some preterms, and they can take many weeks before they have like normal tolerance for food and normal stools. So sometimes also enemas are prescribed and given in the NICUs, and this is also a topic where there is very little evidence, and we do not have a recommendation on that. I think it's very individual by practice, what is practice in that hospital that you work. So those were some comments, but it's a difficult situation.
And from your experience, do you think that extremely growth-restricted infants do need parenteral nutrition for a longer time, and that the increment of daily feeds are slower in these infants? What are your observations there?
We do see that there's those that are growth restricted already at birth, they usually don't have as severe a postnatal growth restriction, and I think they usually you can usually feed them the same. It has been suggested previously that you should feed them slower, but I'm not aware of any good evidence really that you should feed them any differently than appropriate for gestational age infants. So you should probably give them the same per kilogram, and you should not really push the catch-up growth very rapidly. I mean, you should probably be happy that they stay on their centile, and then later on when they approach term age, they could be allowed to do catch-up.
Okay, thank you. Another question for Silke. Would you have more specific data on mental health issues among mothers, like postpartum depression, anxiety, and similar diseases as a result of the setup of separation of parents and babies?
Yeah, we ourselves, we have not documented the mental health aspects. What we have asked is how parents felt in this time, and also how they experienced. And what we have asked is how much they were worried in this time, for example. And 75% of all parents we have asked all over the world in 56 countries said that they were very worried about the situation and providing or have not got any kind of information. And 45%, for example, reported that they had no support at all. And when you just imagine that 1 family in 5 worldwide had no access to their baby until discharge, that says a lot what we will have as mental health long-term consequences afterwards. And we have also asked open question. And one mother, for example, reported that she was so worried when she got her baby after 4.5 months because she was not sure if it is hers. And so that is something what we just have to have in mind. And I guess the data we will have, after the pandemic, I guess will show us what we all have done in this time frame and what we can do, hopefully in the future, to prevent the situation of a total separation. And of course, there are also compromises in the beginning, maybe, of the pandemic, but still we have vaccination, we have hygiene measurements. There is not a need of a total separation as we see it still in many countries all over the world.
Thank you. And there are again some questions on fortifications. Can we add the formula powder to expressed human milk to enrich calories? Or can we add a single protein, or should we add complete fortifiers? So perhaps one of the neonatologists can answer this.
I can say in our practice, there are some studies of pumping and fortifying human milk and using with a regular multi-component fortifier, and that has been, at least in one study, shown to improve postnatal growth. Post-discharge growth, but we wouldn't use it like regularly. We would use it in certain infants who really have difficulty in regulating their own energy intake, and where it's not possible to increase feeds. You have to add some fortifier. We can use lipid fortifiers. We could use multi-component fortifiers. So I think you could use many different
Everything
options,
that makes
and
the
none of
baby
them
grow.
is really very well proven.
Yeah. So everything that makes the baby grow, basically.
Yeah.
Yes. Okay. According to the country, what is available, of course.
Yeah.
And at what age do we expect the premature babies to catch their normal body weight?
Yeah, that's a good question. We have normally you would expect a kind of a catch-up growth within the first 3 to 6 months, but we do have cases with slower catch-up. If they don't have a good, in Sweden we would have a checkup at 2 years. If they are still growth retarded, especially with regard to length, we will do we would do an evaluation, so to rule out a growth hormone deficiency or some other diagnosis. We do know that extremely preterm infants can stay small and thin even up to school age, but then usually when they approach puberty, they will normalize, be similar size as their peers.
Okay, thank you. And there is a question on antibiotics, and I would like to extend the question. Here is, how do we care for preterm babies that are currently on antibiotics? And I would be interested personally if antibiotics in the mother affect the HMOs in human milk.
I would say I'm just thinking, I'm not sure it has been studied in human milk, but for sure, antibiotics to the mother modifies the microbiota, or the mother and the babies. And that has been demonstrated for sure. So I don't know about human milk. I'm not sure it has been studied in that situation, but antibiotics should be as short as possible. And because we know it has long-term, and when I said long-term, it goes to adult age effect, and especially there is a good link now between early antibiotics use and obesity, for instance. And so that's something we need to be very careful about. And maybe HMO could help for restoring appropriate microbiota after antibiotics, and that's something we're working on, and it could be a very interesting option to shorten the side effects of antibiotics. Of course, if a baby has infection, it needs antibiotics, but otherwise we need to be very careful about the duration of antibiotics in these babies and make it as short as possible. That would I say. And HMO may help restoring appropriate microbiota. That's interesting. And that has been shown for other situations. For instance, for birth on cesarean section, as I presented, I presented a slide on that. As compared to vaginal delivery, we know that HMO may alleviate the effect of cesarean section. And likewise, it may alleviate the effect of antibiotics when given appropriately. But we're talking about specific HMO, not all the range.
Thank you. And there's a question for Silke. What for you is the compromise, balancing the guidelines set by the hospitals on COVID precautions and also responding to the clamor of the parents? Again, a very difficult question.
A very difficult question. Well, honestly, we as parents, we didn't want to have any compromise here because we know from the evidence how important it is that parents are there for 24/7. We see the good outcome results also from countries who are doing this consequently over the last years. And we know that kangaroo mother care, breastfeeding, and all this kind of aspects have a huge influence, not only on the emotional or mental health aspect, so also on the outcome of BPD, on the reduction of neck when you have access to breast milk. So there are so many aspects which is hard evidence and medically proven for several years. So this is one thing that we, of course, don't want to see any compromise. What we have to see is what can we do to open or to convince the people who make this or made these decisions to see why it is important to open the NICUs. And of course, with the hygiene measurements, they are needed, and also parents who maybe need to be vaccinated or need to be PCR tested every day to ensure that there is no entrance of the virus in the NICU. But on the other side, we also need then from doctors and nurses the same measurements, because it cannot be that we as parents stand outside of the NICU, but doctors and nurses enter and are not vaccinated or not tested and have not the hygiene measurements. And so this is something what we would recommend when there is no way of negotiation. What it helps, of course, is to have a video streaming for the baby or having hand prints and so on. But again, this is not a replacement of the direct contact, and it's a medical treatment to have kangaroo mother care and provide breast milk and have the voice and the skin and everything from the mother. That's something what we have to ensure to really get this baby healthy. And the outcome is, of course, key. And we all want, in the end, healthy babies who not only survive, but they also should thrive and get a healthy life later on. And with this separation policy, we have no healthy babies, and we also have no healthy parents.
Thank you. I have two final questions, short questions on difficult topics. The first one is related to the fatty acids in pregnancy. At what term trimester should a pregnant mother take DHA and other essential oils to have optimal positive effect on her baby and prevent preterm delivery? Magnus, perhaps? Can you comment on that?
Well, that's a good question. I'm not sure that DHA can prevent preterm delivery. If I'm not completely misinformed, I think rather the opposite can happen even. So I think it's not useful for that purpose. Otherwise, I think it's very healthy to have a good intake of long-chain polyunsaturated fatty acids from fish and seafood. And I think especially important after birth, if you have a preterm baby, that the mother consumes a healthy diet with these components, because then her breast milk will be enriched in DHA, arachidonic acid, and the other LC-PUFAs that are important for healthy development of the baby. So I would focus not on the pregnancy, but on the postnatal period, really. And I think this is a challenge because, as you know, Silke might know also that the availability of healthy food for parents whose babies are in the NICU is quite limited.
Right, yes.
Yeah.
And a final very tricky question of a colleague. If the preterm baby has allergy to cow milk, how do you maintain the nutrition? This is very difficult. I'm not aware of any case of a preterm baby with a severe cow milk allergy. Do you have any experience with that?
Preterm infants, not really, if I can. You may see that kind of reaction when you try to switch from mother's own milk, for instance, to formula too rapidly. And then you may have, because of a load of cow's milk, you may have a problem of allergy and mainly a eosinophilic reaction. And that's, we may have, but you know, when you have that kind, you publish it. So that means it's not often. And really, I haven't seen direct cow's milk as for allergy for premature infants. Only we had a couple of cases when the switch was too rapid from mother's milk to formula, but otherwise, that's why actually we advise, and I think Magnus can tell that we advise progressive switch from human milk to formula.
And donor milk might be your option if you
Yes,
have
sure.
a severe cow mix allergy.
Yeah, we
sure.
have seen a few cases of, we do see a few cases of cow milk allergy in preterms. We especially see with blood in feces, and also some very rare cases with a neck-like presentation with pneumatosis intestinalis, and they are usually, but they are cured by regular extensively hydrolyzed formula, or as you say, Nadia, donor milk.
Right, so this is our disclosure. Mother's own milk or donor milk is always the best. I would like to thank you all for listening to this Nestle Symposium at the World Prematurity Day that is dedicated to the premature infants, their caregivers, their parents. I hope you enjoyed our brilliant speakers and the talks you heard. And yeah, I wish you very pleasant World Prematurity Day, and looking forward to meet you soon in person again outside of the pandemic situation. Thank you very much for listening. Bye-bye.
Thank you.
Thank you.
Bye-bye.
Thanks.
Bye-bye.
Bye.